Assalamu alaikum, Bismillahirrahmanirrahim. Today's talk is challenging scenarios in psoriatic arthritis, comprehensive explanation of difficult cases and innovative approaches. First of all, thank you so much for inviting me for this talk. I want participation from PG trainee. कोई हैं यहाँ पे PG rheumatology के? थोड़े से आगे आ जाए हैं, आपकी पार्टिसिपेशन चाहिए होगी इसमें ना। इस तरह के केसेस हम वार्ड्स में ओपीडीज में देखते हैं। केस सिनेरियो 1, a laborer of 46 years old male presented with itchy papuloscamous rashes on the face and upper extremities from last 6 months. No history of joint pains, photosensitivity, or any systemic involvement. Like there is no respiratory tract involvement, no renal involvement. He was treated with ultraviolet phototherapy but no improvement. Rashes extended to the abdomen and lower extremities also over the period of 4 months. This is a picture of patient. On the basis of these rashes, diagnosis of psoriasis was made and he was treated for psoriasis. After phototherapy, methotrexate was added but no improvement. Later on, anti-TNF inhibitor was also tried but no improvement. बल्कि वो कहते हैं कि जूं-जूं दवा की मर्ज बढ़ता गया. Rashes extended over the period of time, also involved abdomen, back and extremities. तो इसमें क्या हो सकता है अब? What should be the next step? psoriasis को ट्रीट किया लेकिन इम्प्रूवमेंट नहीं हुई, वर्स होता गया पेशेंट. What should be the next step? Anyone? Before switching to biologics, we did skin biopsy. Skin biopsy findings were marked epidermal hyperplasia, focal interface papillary dermal elastosis, mild perivascular inflammatory infiltrates, focal interface dermatitis. पैथोलॉजिस्ट कहता है कि ये psoriasis नहीं है. तो these findings favors SLE. जब पैथोलॉजी वालों ने कहा कि ये psoriasis नहीं है, it could be the SLE. We investigated for SLE and later ANA was positive, high titers, anti-Rho was positive. You know कि anti-Rho also present SLE, musculoskeletal involvement in pediatrics, SLE and cardiac blocks. इसमें कैच पॉइंट्स क्या थे कि डायग्नोसिस psoriasis नहीं है, बिकॉज अल्ट्रावायलेट रेस psoriasis के लिए इज़ अ गुड ऑप्शन, methotrexate इज़ अ गुड ऑप्शन, बट दीज आर नॉट गुड फॉर SLE. जैसे जैसे रेस अल्ट्रावायलेट को देते गए वो वर्स होता गया. SLE में तो हम सन ब्लॉक को यूज़ करते हैं. Diagnosis was reviewed after biopsy and it was found it has a psoriasis-form subacute cutaneous lupus erythematosus. It is a mimic of psoriasis. It is not actually psoriasis. It is a psoriasis-form lesion which is found in SLE. And when we see the literature, treatment was reviewed, hydroxychloroquine, topical steroid, azathioprine was given, and after giving this treatment, 3 to 6 months, patient started to improve. When we see the literature, psoriasis-form subacute cutaneous lupus erythematosus is very rare. 4.5 cases per 100,000 cases, just like SLE. And It is usually diagnosed on biopsy and immune markers. When we see the data of psoriasis, it is common. 60 to 70 cases per 1,000 cases. That's why it was thought first. It is common. And it has a good response, phototherapy, methotrexate, and anti-TNF inhibitors. This is the reference. Now we'll discuss the second case. It is also common, we usually see in OPDs and wards. A teacher of 32 years old presented with swelling and pain of the distal interphalangeal joints from last 1 year duration. No skin involvement, nails are okay. Other joints and systemic inquiry unremarkable. Only swelling of the DIPs, young patient. His lab shows hemoglobin was low, 9 gram per deciliter. Platelets were 127, WBC normal, liver, renal function and urine complete examination all normal. RA factor, anti-CCP also normal. This is the X-ray, sorry, it's a blurred picture. It's showing the erosions on DIPs and also on proximal interphalangeal joints. What could be the differential diagnosis? Young patient, involvement of DIPs, nothing else. There is a pain and swelling clinically. What should be the differential diagnosis? क्या हो सकता है जी? Number 1, psoriatic arthritis. Number 2, rheumatoid arthritis. But RA factor is negative. Seronegative arthritis भी हो सकती हैं. With these symptoms, only NSAIDs were given in the beginning with mild improvement. Later on, low-dose prednisolone was added with no improvement. By thinking it could be an inflammatory arthritis like psoriatic arthritis or rheumatoid arthritis. Methotrexate was added, but its response was partial, not a good response. Our differential diagnosis at that time was psoriasis, psoriatic arthritis and rheumatoid arthritis. जब पेशेंट ठीक नहीं हुआ तो उसको रिव्यू किया गया अगेन आफ्टर फ्यू मंथ्स एंड व्हेन री-एग्जामिन्ड along with swellings on PIPs, there were capitations, bilateral basal capitations. Hemoglobin was also low. Platelets were 105. Other labs were okay. अब क्या हो सकता है? अब एग्जामिनेशन किया तो एडिशनल चीज़ मिली बेजल कैपिटेशंस along with DIP involvement. क्या पॉसिबिलिटीज़ हो सकती हैं? दोनों आप कहने को एग्जिस्ट कर रही हैं. ओके, क्या चीज़? RA with ILD. ओके, ठीक है, ये भी हो सकता है. लेकिन हमने जब मीथोट्रेक्सेट भी दे दी, उसको सारा कुछ दे दिया, ILD क्यों डेवलप हो गया? हमने ट्रीटमेंट तो शुरू से उसका किया था, इतना वर्स तो नहीं होना चाहिए था. ILD इट्स अ गुड डिफरेंशियल डायग्नोसिस. जब हमने उसका HRCT किया तो इंटरस्टिशियल लंग डिजीज़ अगेन कि उसका ANA करवाया तो उसका ANA एंटी DS-DNA वाज पॉजिटिव. ठीक है, यू नो in the past it was considered erosive arthritis is less likely in SLE, but now after the presence of the good diagnostic tools like MRI, CT scan, erosions is also very common in SLE, and more than 30% of cases have erosive arthritis in lupus erythematosus. These two cases were mimicked of psoriatic arthritis, and later on diagnosis was different. केस सिनेरियो 3, ये भी हम बड़ा कॉमन देखते हैं, ये आपको पता होगा इसका ज़्यादातर को. A factory worker of 43 years old male presented with history of big toe pain from last 3 months. Initially, pain was mild, with good response to NSAIDs. Now, from last 10 days, pain is very severe. Toe was red and tender. On examination, there was a psoriatic patch on the skull. CRP was 45, uric acid 7.8, RA factor anti-CCP negative. क्या डिफरेंशियल डायग्नोसिस होगा जी? ठीक. और वो तो गाउट हो गया ना, ठीक है, एसोसिएशन होती है उसकी. और क्या हो सकता है? ये पिक्चर थी उसकी. It was red, hot, tender, podagra and dactylitis. उसका psoriatic patch भी था, आपने वो भी ध्यान में रखना है. Dactylitis is a complication of psoriatic arthritis. He was treated with NSAIDs, allopurinol, prednisolone for few days, along with colchicine. Patient improved, but again symptomatic. Partial improvement. It was thought it is not a gout, it might be a dactylitis. Allopurinol discontinued, and he was given methotrexate along with NSAIDs and low dose prednisolone. But again, there is a partial improvement. Biologics given, etanercept was tried, mild improvement, again symptomatic after few weeks to few months, red, hot, painful. क्या पॉसिबिलिटी हो सकती है? एक्चुअली इस पेशेंट को दोनों चीज़ें थी, हाइपर यूरिसीमिया भी था और डेक्टिलाइटिस भी था. हमने एलोपिरिनोल डिसकंटिन्यू कर दी ये सोचते हुए कि डेक्टिलाइटिस है. जब एलोपिरिनोल डिसकंटिन्यू की, उसके भी सिम्टम्स आने शुरू हो गए और दोबारा एलोपिरिनोल ऐड करनी पड़ी उसमें. नाउ पेशेंट इज डूइंग वेरी वेल. देयर आर लॉट ऑफ स्टडीज शोइंग देयर इज हाइपरयूरेमिया इन psoriatic arthritis because of high cell turnover and breakdown of the nucleic acid. जब उसको री एग्जामिन किया, री टेस्ट किया, उसका यूरिक एसिड 9.3 हो गया था. This is the last case. Case scenario number 4. A patient, 32 years old, from Gujranwala. She shifted to rheumatology department from dermatology department. He had a complaint of joint pains from last 2 months. Both knees and right ankle were tender, swollen and warm. Biopsy proven psoriasis. There is also history of psoriasis. But there is no history of inflammatory backache, dactylitis, enthesitis, red eyes, any history of oral genital ulcers, altered bowel habits. No family history suggestive of psoriasis. However, history of nail involvement was present. There was pitting. There is also history of low-grade fever, 9900 in the beginning. He had a fever. Cultures were negative. All cultures were negative. For his psoriasis, topical medicine was given. From last 2 months, he was started methotrexate. Maybe fever because of inflammatory arthritis की वजह से हो रहा, low grade. Methotrexate was added. But fever and psoriasis was not under control. फीवर 100 तक हमें हर वक्त देखते थे, 9900 इस रेंज में उसका फीवर रह रहा था, सेटल नहीं हो रहा था. Active synovitis, both knees and right ankle. No evidence of other joints or dactylitis. Nail pitting was present. Pasi was 14%. No oral genital ulcers, lymphadenopathy, systemic examinations, unremarkable. Blood count, liver function tests, RFT is all normal, but CRP is high. Dose of methotrexate was increased 10 to 15 milligram per week. Patient then evaluated for the start of biologics. Improve नहीं कर रहा था, ना arthritis ना psoriasis. Low grade fever था, infection screen negative थी. ये सोचते हुए उसको biologics के लिए प्रिपेयर किया गया है. BC, T-spot normal, chest X-ray normal. Despite increasing methotrexate, his fever, arthritis worsened. नहीं ठीक हुआ उसका. क्या पॉसिबिलिटी हो सकती है? HY is the possibility. ठीक है. Methotrexate stopped. Again, cultures were sent. Culture, blood culture, urine culture, skin swab, all negative. Broad spectrum antibiotics was started, but fever not settled. Later on, infection screen turned out to be negative, fever not settled. Okay, fine. Then evaluated for HIV. On careful examination, there was also a history of high sexual activity, which patient initially denied. Now thrush was also present. Rapid antigen testing for HIV was positive. HIV ELISA done twice, it was also positive. HIV RNA was also positive. As CD count were 350 per mm3. Methotrexate stopped, patient was put on heart therapy. After 3 months of therapy, viral load decreased, fever settled, there is improved arthritis. Probably arthritis HIV की वजह से उसका ठीक नहीं हो रहा था. Methotrexate बंद करने से, हार्ट थेरेपी शुरू करने से इम्प्रूव होना शुरू हो गया. इसकी भी हमने स्किन बायोप्सी करवाई थी और इसकी फाइंडिंग थी पैराकैरियोटोसिस, डिमिनिश्ड ग्रैनुलर लेयर्स, dilated blood vessels, thinning of subpapillary plates, intermittent parakaryocytis, perivascular infiltration of the lymphocytes, the presence of occasional neutrophil aggregates in the epidermis. हमने सोचा कि कहीं ये psoriasis फॉर्म ही जिस तरह पहले आ गया कि ये वही ना हो, लेकिन it was psoriasis. और the histological features of HIV-associated psoriasis might be identical to classic psoriasis. However, diagnosis may be difficult. In HIV-associated psoriasis, there are few T cells. Dyskeratotic keratinocytes and lymphocytoclasses, but plasma cells are common. Since plasma cells are easily detected on the skin section, stained with H and E stain, the presence in psoriasis skin biopsies should be, presence of यहाँ पे miss हो गया, basal cells usually यहाँ पे लिखना भूल गए, presence of basal cells should arouse the suspicion of HIV. एक तो T cell कम होंगे उसमें और दूसरे basal cells होंगे उसमें. This is all for 4 cases. Now take home message is always review the case when patient is not improving. Always re-examine, consult with other specialties and senior, and there is no alternative of history and examination. Thank you so much. Any questions?